Fabio, please be my guest. I want you to introduce yourself for our audience. I guess it will be better than my macaronic English.
No, absolutely. Thank you so much. Bom dia. Bom dia and tudo bem. This is how much I remember of Portuguese. It's a language I'm trying to learn because I really enjoyed my time over the last 2 years in Brazil. So hopefully I'll be back. I'll be back soon, and I will meet you in person. Yes. So I'm at the moment. I'm working in Bologna in a private referral hospital. It's called Portoni Rossi. It's part of Anicura, which is part of Mars Veterinary Health. I'm a gastroenterologist. At the moment, I'm also the director of the hospital. So this is a new role I just taken up roughly a year ago. I graduated in the south of Italy in Bari. Then I moved to the UK. I worked in private practice for a few years, and then I started an internship, a rotating internship at the University of Edinburgh in Scotland. And after that, I did my residency at the University of London. So I took my American diploma in internal medicine. And the following year, I took the European diploma. I worked in private practice in the UK for around 5 years. And then 8 years ago, I made the decision of moving back to Italy. So I started this journey here in Bologna. I love gastroenterology. Right now, I'm head of the European Society of Gastroenterology. We had a meeting in Greece a few weeks ago, and there were a few friends from Brazil, which was very, very good to see. So it's a society, and we want to collaborate with Brazilian societies, because I know that in Brazil there are many gastroenterologists, many people passionate about gastroenterology. So I was very impressed by the level of knowledge when I visited. And so today I accepted very easily the invitation from you to share my knowledge on FMT. It's a practice that I started here in this hospital around 4 years ago, and now we're really doing quite a lot of these treatments in several applications. So what I would like to do today is to briefly introduce the topic of the intestinal dysbiosis, which is what we try to manage when we do FMT. We will see what the evidence in dogs and cats is regarding the efficacy of fecal microbiota transplantation. You'll be surprised to see that there are many clinical scenarios where FMT can actually make a difference. And then we will go into the details of how we select the donor and how we actually administer FMT in the majority of cases, because there are several ways of administering an FMT, but we use mostly one route. And I was part of the consortium that wrote the guidelines for the clinical guidelines for FMT in private practice. So I can share the work that the whole group did. So the intestinal microbiota, you probably now know, you're probably sick of hearing about the intestinal microbiota. We know that it's a very important component of the intestinal environment, and we know that the intestinal microbiota is able to affect not only the gastrointestinal tract but also the whole body. So it's a very important actor of the intestinal environment and the body as a whole. Here you see a picture of feces, and that's the what we call the luminal microbiota. And on the right hand side you see a small picture, a histopathological picture. It's actually an immunofluorescence picture where you see this huge mass of I suppose, orangey microorganisms. I'm colorblind, so I don't know. It might be a different color, but I see it orange. On the top, in the middle, you see, this is the intestinal microbiota. In the middle, you see the layer of mucus, the protective layer of mucus that divides the microbiota from the intestinal epithelium. And so you can see how closely related the microbiota and the intestinal epithelium is. Now, we know in people, in dogs, in cats, the microbiota is very diverse. We're talking about trillions of microorganisms. Bacteria are the most heavily represented kingdom of this ecosystem. And we know that in people, in dogs and cats, we have around just over 1,000 different species within this huge bacterial ecosystem. Now, the intestinal microbiota is responsible of the growth, the development of the structure, but also of the function of the intestinal tract and the immune system. But it's able to do this through its very important metabolic function, because the microbiota is able to produce beneficial metabolites from dietary substrates, but also from endogenous compounds. For example, the microbiota, starting from carbohydrates, complex carbohydrates, and fiber, can produce short-chain fatty acids, which we know are very important, not only as energy source, but also as immunomodulatory compounds. And many bacteria can produce short-chain fatty acids, but some are particularly efficient. For example, Faecalibacterium prausnitzii is probably the best bacterium when it comes to digesting fiber. We can, bacteria can produce other metabolites from amino acids, lipids, and they can also produce what we call secondary bile acids. And, a lot of the attention now is focused on this metabolic pathway, the conversion of primary bile acids into secondary bile acids. And only bacteria belonging to the group called Peptacetobacter can actually do this. And the most important bacterium within this group is Peptacetobacter iranonis. So I will focus a little bit on this metabolic pathway because it's very, very important. So primary bile acids, just to recap, they're actually produced by the liver, and they enter the intestinal lumen through the biliary tract, where they are responsible for the digestion and absorption of lipids. Okay? Now, the majority of bile acids are returning to the liver through the enterohepatic circulation, but some of them are actually converted by the intestinal microbiota, our friend Peptacetobacter iranonis, into secondary bile acids. The majority of these are excreted through the feces, but a component of secondary bile acids are actually absorbed, and they work systemically, so not just within the intestinal tract, but also systemically, and they have a very strong anti-inflammatory property, and they can also inhibit the growth of pathobionts. So bacteria with the potential of being pathogenic, but they usually live within the normal flora. And so iranonis is very important because it's the only bacterium that can actually lead to this important metabolic shift from primary to secondary bile acids. I'll show you a demonstration. This is a study from the University of Texas, where they actually look at the quantity of iranonis in the feces of puppies, and as you can see on the left-hand side, we can conclude that up to 6 weeks of age, puppies don't have iranonis. And so if you look at the total secondary bile acids in the feces, they're not present, because the only bacterium responsible for their presence is not there. And as soon as iranonis populates the intestinal lumen, you see all of a sudden the appearance of the secondary bile acids in the feces. And on the other side, you see how Clostridium difficile, which is a pathobiont, overgrows when Iranonis is not present, and there are no secondary bile acids, and disappears as soon as the bile acids are there. Okay, so this is a beautiful demonstration of this metabolic pathway. But we'll go back to Iranonis and bile acids in a second. So whenever the intestinal microbiota shifts, so from a condition of normality into a condition of abnormality, we call it dysbiosis. Okay, so it's a very vague definition. So intestinal dysbiosis is a syndrome. There are several patterns of dysbiosis. For example, you could just have an overgrowth of a specific group of bacteria, for example, the enterobacteria. And these are bacteria that are very avid of proteins. So they produce a lot of compounds from proteins. And these are compounds that can actually lead to inflammation. So this is a pattern of dysbiosis. In some cases, some dogs, some cats lose the protective mucus layer. Therefore, intestinal microbiota, it's a closed intestinal epithelium. And that alone can actually lead to an excessive immune stimulation. Okay, so that's another pattern of dysbiosis. You can actually have dysbiosis secondarily through a wrong diet, like a poorly digestible diet, that leads to the presence of a lot of osmotic substrates in the lumen. These substrates are used by the bacteria, and this leads to production of compounds that cause diarrhea. They cold water in the intestinal lumen. And of course, we could have a situation that is actually very common in our practice, where you lose completely one of the beneficial bacterial group, for example, our friend Iranonis. Therefore, you have a lack of secondary bile acids production, or on the contrary, an excess of primary bile acids, and this can lead to inflammation and an overgrowth of pathobionts. For example, Clostridioides difficile, like I showed you earlier on. So dysbiosis is a syndrome, it's not a disease. It's almost like a clinical science, and it's very common in small animal practice. And nowadays we can actually diagnose dysbiosis in private practice by using a qPCR on a fecal sample. This is a test that we now have available. You probably have available in Brazil as well. It's been validated by the University of Texas, and it's based on the absolute quantification of the total bacteria and 7 key bacterial groups in the feces of a dog or a cat. Now, through an algorithm, this test allows us to have a final index that tells us whether that dog or cat is dysbiotic or not. And I will show you in a second. So these are the bacterial groups that make this test. I highlighted 2 bugs that I just mentioned earlier on. So Fecalibacterium prausnitzii is a beneficial bacteria that produces short-chain fatty acids, and Peptacetobacter iranonis. Okay, these 2 bacteria actually play a role in this index. Now, the interpretation is this. So whenever you have an index below 0, so negative, that's what we consider a normal situation, so eubiosis. So whenever the index is above 0 in dogs and cats, we have an abnormal shift in the intestinal microbiota. And the higher the index, the more significant the shift is compared to normal. Okay, so the cutoff for a significant shift in dogs is an index of above 2, and in cats above 1. And as I mentioned, this test has been tested, validated in several clinical conditions. And you can see that dysbiosis typically is most commonly associated in dogs with chronic enteropathy. A very good proportion of dogs with chronic enteropathy have a high dysbiosis index, and also antibiotic use. And the same situation is true for cats. So chronic enteropathy, antibiotic administrations are the most common conditions associated with intestinal dysbiosis. And if we're talking about how to manage dysbiosis, you'll see how FMT can actually help in these scenarios. Now, in people, we know that dysbiosis has been associated with a variety of diseases, mostly chronic inflammatory conditions, also outside of the intestinal tract. So you probably heard about the axis of the gut and the brain, and the gut and the skin, and the gut and the heart and the lung. And this all stems from a shift in the intestinal microbiota. In dogs and cats, we believe the same is happening, but right now the strongest evidence of association with dysbiosis is mostly with gastrointestinal conditions, or with antibiotic treatment, or with exocrine pancreas insufficiency. But there are some studies that show an association with metabolic diseases like diabetes and obesity, or chronic kidney disease in cats, and even with immune-mediated diseases like atopic dermatitis. Okay, so probably what we said about people is true for dogs and cats. So intestinal dysbiosis is so important, it's so central in what we see, then we need to think, how can we manage dysbiosis? Okay, so how can we modulate the intestinal microbiota? Maybe to prevent shifts, also to manage shifts once they have happened. And there are several ways we can actually modulate the intestinal microbiota according to the pattern of dysbiosis and the severity, the duration. But the treatment strategy that is more directly affecting the intestinal microbiota is fecal microbiota transplantation. Okay, so this is what we'll focus on. So there are several definitions of FMT. I like this one. So FMT means infusing fecal matter from a healthy donor into the GI tract of a recipient to introduce, hopefully reestablish, a healthy, stable microbial community in order to treat, not to cure, in order to treat a dysbiosis-associated disease. Okay, so this is the definition I like. Now, in people, FMT is being used for many years, so much that we have very specific guidelines. For example, from the American Gastroenterologists Association, they actually clearly identify the clinical applications and the protocol for FMT in people. And what we know in people that the most commonly recognized condition where FMT is actually efficacious is the infection from Clostridioides difficile. Okay, whilst in dogs and cats it's not so worrisome, it is very worrisome in people. They acquire it typically when they are in the hospital and they've been treated with antibiotics. And if they accidentally swallow the spores of that are present in the environment from this anaerobe. And now this is a disease that is characterized by a severe enterocolitis, very severe, that has a very high risk of relapse. And many of these cases are resistant to antibiotic treatment. So some people die because of C. difficile infection. And besides this, the cost to manage these patients for the health organization is actually quite heavy. Now we know now for more than 10 years, I'd say 15, 20 years in people, that in this scenario, FMT has a success rate of more than 90% cure. And it has a very safe treatment. Okay, now in people that are studying and researching FMT, many other conditions, but this is the most commonly recognized application. So I told you that a group of people like me, but also like pathologists and lecturers from many universities got together and wrote these guidelines for people like you that want to start doing FMT in practice. So we worked on donor selection, FMT preparation, so how to administer it, but also on when to use it. Okay, and what we basically started with was looking at the scientific evidence for the efficacy of FMT in dogs and cats. And unfortunately, like many times happens, we didn't have a lot of studies. Most of the studies were underpowered, uncontrolled, so without a placebo control group. But yet we have a few studies that show convincing evidence of efficacy, which I summarized in this slide. So we have evidence of efficacy in infectious diarrhea, specifically parvoviral diarrhea in puppies. Several studies showed evidence of this efficacy. In dogs with uncomplicated diarrhea, including hemorrhagic diarrhea, in cases of antibiotic-induced dysbiosis and GI signs, especially in cats, and also chronic enteropathy. So I want to show you the most important studies that we looked at. This is a study actually from Brazil from 2018 that has been replicated by other research groups showing the same results. Okay, so we can happily say that FMT helps in puppies with parvoviral infection. In this study, they had 66 cases. They were randomized into a group receiving standard treatment and a group receiving standard treatment with FMT. FMT was administered soon after admission in the hospital through an enema, which is the most commonly used route. And what the authors were able to show is that in the group of FMT, there was a much higher proportion of puppies that were dismissed from the hospital, as you will appreciate here, within 2 hours from FMT, compared to the standard treatment group. There was no difference in survival rates. So the conclusion here is the FMT shortens the duration of hospitalization in puppies with parvoviral diarrhea. So I don't know whether you use FMT routinely in these cases, but we do because of this evidence. And this is the study that we designed together with Dr. Vecchiato from the University of Bologna. We wanted to see whether dogs with chronic enteropathy, mild form of chronic enteropathy, unresponsive to 2 dietary trials, would respond to FMT. So we selected 20 dogs that hadn't responded to a hydrolyzed diet or a home-cooked single ingredient diet after 2 weeks of trial. And they received 1 to 2 FMTs through an enema. They were followed up to 3 months with clinical score, fecal dysbiosis index, and also metabolomics. And what you'll see is the population of dogs was very various. So many dogs had diarrhea, but some dogs didn't have diarrhea. They only presented with bloating or abdominal cramps or vomiting. They were mostly young dogs. You see the average age was less than 4 years. Mostly small-sized dogs, and they had mild disease. You see the mean clinical activity score was 5. And so what you will appreciate is that compared to time 0, so before the FMT, clinical activity score improved with statistical significance. Fecal consistency improved, and this improvement was maintained up to 90 days. When we looked at the dysbiosis index, so the dysbiosis of these cases, we were amazed to see that around 50% of dogs were not dysbiotic. So they had an index below 0. And therefore, despite they responded to FMT, even dogs without dysbiosis did so. Now, the dogs with the red dot were dogs that had received antibiotics and had a very low iranonis, and you will see that over time these cases decreased. And here you see the abundance of iranonis in the feces of these dogs. You see the number of dogs with low iranonis improved after FMT. When we looked at the bile acids, what you'll see is that the primary bile acids, so the bad bile acids, decreased after FMT by more than 50%. And when we looked at the good bile acids, the secondary bile acids in the feces, they improved by more than 40% after FMT. And this was probably related to the increase of iranonis, the return of iranonis in the feces. When we followed up, so overall, the success rate of this population, 18 out of 20 dogs were in remission after FMT at 90 days. Only 2 cases had relapsed within the study period. But when we followed up these dogs a year on, we were surprised to see that 10 out of 17 dogs were still in clinical remission. So 1 to 2 FMT was sufficient to keep them in remission. And the remaining 7 cases had relapsed, but they again achieved remission after restarting FMT. And now another study that it's very important to cite, it's the study from Linda Torres. She's a Swedish gastroenterologist. She actually studied the efficacy of FMT in dogs with partially immunosuppressive responsive enteropathy or non-responsive chronic enteropathy, around 40 cases of different breeds. There were many reasons why these cases tried FMT, not just the persistence of diarrhea, but sometimes a lack of appetite or difficulty in gaining weight or the difficulty in reducing the dose of steroids. All of these, or immunosuppressive drugs, all of these dogs were receiving immunosuppressive treatment. You see, these dogs were suffering from chronic enteropathy for quite a long time, a median of more than 2 years. They had tried several dietary strategies and that didn't help. As you can see, the majority of these cases were receiving 1 to 2 immunosuppressive treatments, so quite a severe and different clinical population from the one we studied in Bologna. And looking at the results, 34 out of 41 cases received 3 FMTs. These were the cases that actually responded, because the authors didn't administer a third FMT if they didn't see an improvement after the second FMT. So 7 were the cases that didn't respond. When they looked at the duration of the clinical response, they classified the responders in long-term responders, so up to 6 months remission, clinical remission, versus the short-term responders. So the cases that responded, but the remission lasted less than a month and a half. And then they have the non-responders, or which were cases that didn't respond, or they responded but relapsed within seven days. So that's a 70% clinical improvement rate, as you can see from the median clinical activity score that decreased after FMT. And another treatment point was the ability to reduce immunosuppressive treatments, and this was possible in 30% of cases, okay, which is a secondary treatment efficacy point. When they looked at the fecal dysbiosis index, so the severity of the dysbiosis in the 2 groups, long-term responders versus short or non-term responders, what the authors were able to show is that the dysbiosis of the long-term responders was statistically less severe than the dysbiosis from the non-responder groups. Okay, you can see a median dysbiosis index of minus 0.2 versus 3.9. And if you remember, the cutoff in dogs for severe dysbiosis is 2. And when you looked at the groups of severity of dysbiosis, you can see that almost 80% of dogs that responded, they either had no dysbiosis or mild dysbiosis, versus 70% of the non-responders that had severe dysbiosis. And this is a very important clinical data. And in this study also, they looked at the metabolomics, bile acids, concentration, and what you can see is that in the long-term responders, there was a good reduction of the primary bile acids in the feces. These are the secondary bile acids. You see many dogs, 6 dogs in the responders had an improvement of their secondary bile acids after FMT, almost indicating a return to a normal metabolic pathways, versus the non-responders, where the majority of dogs continue to have a lack of secondary bile acids. Now, we also have evidence on the efficacy of oral FMT, meaning lyophilized feces that are encapsulated and administered orally. In this study from Italy, with 27 dogs treated for 30 days, they demonstrated a clinical improvement based on the owner questionnaire in 74% of cases. In this case as well, you will appreciate that the severity of the disease of these dogs was quite mild, because the clinical activity score was 5, which is typical of mild disease, and decreased down to 2. We don't have a long-term follow-up, so we don't know whether oral FMT can actually induce sustained remission. And we have a similar study in cats with chronic GI signs. This is a study from United States with 70 cats with several GI diseases, some of them with chronic enteropathy. They also were treated for 30 days with oral encapsulated FMT, lyophilized FMT. And based on the owner perception, 77% of these cats, many of which had probably antibiotic-induced dysbiosis, responded. Okay, but again, no data after 15 days. But we also have a study in cats. This is a recent study from Greece, from Dr. Xenoulis and his doctoral students, where they actually evaluated the efficacy of FMT versus no FMT in a pretty variable population of cats with chronic GI signs. As you can see, these cats also had small cell lymphoma. Okay, they were randomized into 2 groups, treated with standard treatment plus FMT versus no FMT. They didn't see a statistical significant difference in the prevalence of clinical improvement, in the sense that both groups, as you can see, had an improvement of the clinical signs with treatment. So the conclusion was FMT doesn't improve efficacy of standard treatments. But however, many cats had lymphoma. Treatment was not standardized, and only 1 FMT was administered. And I will show you that this is not really what we typically do in chronic enteropathy. So that's probably why they couldn't see a difference. And this is a beautiful study yet to be published that I like to mention all the time, that shows how FMT can actually manage, treat, cure antibiotic-induced dysbiosis, especially if it's not chronic. This is a colony of healthy cats that received antibiotics, the typical amoxiclavulanate, for 10 days. Now, before this, they had collected and stored their fecal microbiota. Then the cats were randomized into receiving FMT or placebo. And what you can see is that all cats except 2 developed severe dysbiosis after starting antibiotic. Here we are, index well above 1 in almost all cats but 2. And then the cats with FMT had a return of the dysbiosis index within normal versus the cats that didn't have FMT, that remained dysbiotic up to 56 days after the end of the antimicrobial treatment. Okay, so a short course of antibiotics can actually induce long-lasting dysbiosis. And FMT can actually be an option for this type of dysbiosis. So I don't know whether there are any questions about these studies, but we can perhaps leave the questions for the end. I want to move now into the second part of the talk. So the specifics of how we select donors, how we prepare feces, and how we administer FMT. And perhaps we'll see whether there are any differences from what you are doing. So these are the recommendations that you'll find in the guidelines I mentioned earlier on. So a suitable donor should be adult, okay, because we know that with age the microbiota can actually shift, and young animals are a tendency of being almost dysbiotic. So at least 1 year of age, up to at least the 75% of their life expectancy. Okay, so that's the age of suitable age range suitable for donation. They should be clinically healthy, so no clinical signs, no medical history. They don't need to have lab work within normal limits if they have no clinical signs. They have to be in good body condition. For cats, ideally, we would prefer cats that live alone. They are indoor, because as you know, there's a higher chance of cross-infection when there are multiple cats, and cats are allowed to roam freely in the environment. Now, we don't recommend sequencing, so 16 RNA sequencing, shotgun sequencing, in order to select a normal, a good donor, but we do advise to perform a fecal dysbiosis index that has to be below 0. And I can tell you that typically a healthy dog has an index below 4, and a healthy cat has an index below 2, so -2. Okay, so this is what we tip the average donor's dysbiosis index. We have to rule out all the enteropathogens. So we have to do an extended PCR panel to rule out parasites and also bacteria like Salmonella, Campylobacter. Of course, fecal flotation to rule out endoparasites. In cats, we recommend ruling out Trichomonas blackburni or fetus. It's now called blackburni. And although we're still debating whether this is really necessary, we recommend excluding cats that are carrier of enteric coronavirus, and of course FIV, FRV negative. So there's a bit of investment, financial investment, to consider when you are selecting a donor, but this is recouped when you charge your clients for each FMT. So I think it's worth following this recommendation. Now there are several ways you could go along to give an FMT. In Italy, there's only one company that can actually sell lyophilized FMT, so freeze-dried, pulverized feces, encapsulated in capsule and administered orally. The majority of practices, including ours, administer FMT through an enema. And what we do, we typically collect feces from our donor. You can actually prepare them while they're fresh, which is up to 6 hours from collection, from voiding. But the majority of times we refrigerate them or even freeze them. In the fridge, they can actually be suitable for up to 2 days before you actually prepare them. And if you want to store them, freeze them, if you add glycerol in a ratio of 1 to 10, so one part of glycerol, 10 parts of liquid feces, this will prolong the duration of your fecal preparation. For example, minus 20 degrees freezer, they can last up to 6 months versus 1 month without glycerin. I don't usually use glycerin. I will show you my protocol, just because our donor lives near the hospital, so we can have feces whenever we want. Okay, so we don't need to. Also, because glycerin sometimes can cause a bit of diarrhea. And you don't need a special room to prepare your feces. You just need a surface, a plain surface, time, patience, but you don't need very expensive equipment. So this is what we do. For example, we weigh the feces of the donor for each donation, because we know that the dose of FMT for the recipient is based on their body weight. So we need to know how many grams of feces we collected. Typically, the range of those goes from 2.5 to 5 grams of feces per kilo of body weight of the recipient. We typically stay in the middle, especially in large breed dogs. We blend the feces with saline, non-bacteriostatic sodium chloride 0.9 solution. We put it in a zip bag, in a food zip bag, with 1-to-1 ratio in dogs. This is our protocol, 1-to-2 ratio in cats, because feline feces are typically more fibrous, so they need more diluent. So we break down the feces manually very well, and then we pass them onto a fine kitchen sieve, and we collect our FMT with syringes that we label and we store at minus 20, as I said, for up to a month. Okay, unless we want to administer the FMT straight away. And the administration happens with a soft, non-traumatic rectal catheter. Typically, diameter is 12 French, both for dogs and cats. Now, in dogs, we don't usually need sedation. We just need a very good amount of lubricant. And I will show you how we do it in a second. In cats, sometimes you need sedation. Okay, Italian cats are quite wild, and often they need sedation. We recommend fasting before the FMT, especially for cats if they need to be sedated. And we encourage clients to take their dogs out to defecate, so that you have an easier access for the rectal catheter. And typically we ask the owners not to walk dogs up to 6 hours after the FMT. For cats, we usually keep them in their carrier. That usually inhibits them. They don't usually defecate, and that's typically enough. And so this is a video that shows you how easy it is. So I'm holding a soft rectal catheter, is well lubricated. I measured from the anus to the last rib, and I put a mark on my rectal catheter. It's very easy to insert. You go up to your mark or until you feel resistance, and then you start administering. Sometimes I play a little if I'm against the transverse colon. And this is a small breed dog, so you can see how concentrated the FMT is. You can see my intern is not helping, so it's just watching. And this is to show how easy it is. The owner is at the head of the dog. If the dog is well behaved, I like the owners to be in the room. You see, I'm chatting, I'm explaining why the rectal catheter is twisting. It's much longer than actually needed for the size of the dog. We are laughing, chatting. The dog is tolerating the treatment very well. And once I'm at the end, I like to flush the catheter with some saline, and then I pull it out. So very easy. Anybody can do it. And for cats, the protocol is the same, with the difference that sometimes you have to sedate them, and we do use more saline. So, but I will show you in a second a case. So just before finishing, I want to show you some real cases. So this is an Alaskan Malamute that came to see me with severe chronic large intestinal diarrhea, really severe. In his history, he always had on and off GI signs that typically easily managed with dietary change, until 3 months before I saw him, when the diarrhea became persistent. So they tried a hydrolyzed protein diet. They tried a single protein diet. They tried home cooked diet, and he didn't respond. So they did a gastroduodenocolonoscopy, biopsies, histopathology. They found mixed inflammation, and they started immunosuppressive treatment with high dose of glucocorticoids and probiotics. Skoll was still receiving these medications when I saw him, because according to the vet and the owner, that was the only way of sort of managing the diarrhea. So at the time of presentation, like you do, we try to score the severity of presentation, which was very high in Skoll's case. He defecated several times a day. Imagine his size. I mean, a 50-kilo Alaskan Malamute defecating, very liquid, very soft, full of fresh blood and mucus feces. And over time, he lost his appetite. He started vomiting. He lost a lot of weight, a lot of muscle tone, and he had all the side effects of steroids treatment. So polyuria, polydipsia, and exercise intolerance. You see, his clinical activity score was quite high, so this is typical of severe disease. At least it was when we saw him. And on his staging diagnostic workup, he had all the signs of steroid treatment, so increased liver enzymes activities. But other than that, small adrenal glands, which you typically see, but from an ultrasound point of view, things didn't look too bad. So we suspected he was actually showing signs of toxicity from treatments, in addition to the signs of his chronic enteropathy. So we elected first to try a multimodal treatment strategy. So we tapered and stopped the steroids that he was not tolerating. We started a fiber-enriched diet. You know, the fiber is actually quite helpful in cases of colitis, especially for like very low fecal consistency. And in his previous diet, there was no fiber, so that was a logical choice. And we continued the multi-strain probiotic. Now, just by removing steroids and introducing fiber, we saw an improvement, because his clinical activity improved significantly. His fecal consistency improved from 7 to 5 out of 7, but still not normal. His appetite improved, his exercise tolerance improved, he put on weight, and his PUPD resolved. But this is probably because we removed the toxicity of steroids. Okay. So completing the clinical staging, we requested a fecal dysbiosis index. Actually, because the owner was quite happy with the initial response, we were able to check the dysbiosis index 3 times in 6 months' time. And you can see that the index remained above 2, so indicating severe microbial shift, so severe dysbiosis. And 6 months into the treatment, the abundance of Iranon is actually decreased below the metabolic cutoff. Okay, so at this abundance, you don't have conversion from primary to secondary bile acids. Primary bile acids can actually cause severe colitis. So this is actually quite important. So what we decided to do was to do FMT. Now we gave 2 treatments. That means a total of 4 enemas, 1 to 2 weeks apart. And what we noticed was an amazing response. So his clinical activity score went back to 0, fecal consistency almost normal, and it was basically absolutely normal. And when we looked at the fecal dysbiosis index after the 2 FMT treatments, you'll see that we were able in February, so that means 5 months after the initial FMT treatments, to actually achieve eubiosis with Iranonis back to normal abundance. Okay, and this is why FMT can actually allow a clinical improvement. However, we know, remember the study from Linda Torres, we know that once dysbiosis is severe and chronic, the likelihood is that the clinical signs will relapse, and that's exactly what happened with Skoll over time. So he had several relapses, but we all managed to control them with FMT. Another case I want to show you, and it's not by chance that I chose a cat, it's Lupin. He's a young domestic short-hair cat that was referred to us for refractory chronic mixed intestinal diarrhea. Now, interestingly, in his history, we had the responsiveness to amoxiclavulanate. So he had undergone several treatment trials for his diarrhea. None of those worked, and then the referring vet desperately resorted to prescribing antibiotics with an initial response. And every time they discontinued antibiotic, Lupin relapsed until the point though reintroducing antibiotic didn't help. So he was no longer antibiotic responsive. Now I want to show you what happens to cats when you give antibiotics. You saw it earlier on in the healthy colony cats, and this is exactly what happened to Lupin. I mean, his dysbiosis index was exactly where you'd expect it, so well above 1, so a severe shift, and exactly what we expect happened. So he had lost completely Hiranonis, which in cats happens most commonly with antibiotic treatment than with chronic enteropathy. Okay, so it's much more common with antibiotic-induced dysbiosis than chronic enteropathy. So these are my cats, Leone and Regina. They are to this day, they are our fecal donor. This is the dysbiosis index, is minus 0.24. You can see it has perfectly normal key groups, abundance. So in Lupin's case, we tried a fiber-enriched diet with the addition of probiotic, and we treated him with FMT twice, 7 days apart. This is Lupin undergoing his FMT. He's growling. You can't hear it because I removed the sound. We actually, in this case, using a feeding tube, an esophageal feeding tube that is a little bit softer than I would have preferred, but it was well tolerated, and it was very easy to insert. And you see, he's tolerating his FMT without any problems. And this is what happened just 1 week after the last FMT, and this is 1 month after the second FMT. And this is the post-FMT dysbiosis index. So with an index of minus 0.8, okay. Now, just to wrap up, I show you which clinical scenarios FMT has scientific evidence of efficacy. I showed you a couple of cases, but now we know that FMT can actually work in many other situations. For example, dogs with boxers and French bulldogs with granulomatous colitis, refractory to antibiotic because of antibiotic-resistant E. coli strains. Cats with refractory trichomonas infection, refractory to ronidazole. Dogs, puppies and kittens with refractory Giardia infestation. And there's also some evidence for constipation in cats and obesity in cats. Okay, so soon you're going to see publications with showing some evidence of this. And just to show you like an unusual application. So this is Francisco. He's a Persian, actually a Himalayan cat, young, 1 year of age. he struggled with severe large intestinal diarrhea since he was very young, and he was positive to trichomonas and coronavirus. He was treated with ronidazole, the usual protocol, plus fiber-enriched diet, but he didn't respond. He was treated again with ronidazole with no response. They tried tylosin with no response. So persistent clinical signs, a persistent trichomonas fetus. And so we decided to try FMT, and in addition, of course, to fiber and probiotics, and we were quite amazed to see how well he responded. Okay, so the most interesting part was that his trichomonas PCR, repeat PCR, was negative. Okay, so we were probably able to decolonize his colon from trichomonas with a healthy fecal microbiota. So this is our still our only fecal microbiota donor. She's an Australian Shepherd called Kira. Soon she's going to be retiring, and so we're going to be look out for a new donor. And I hope you enjoyed this presentation and that you found it useful. And I'm happy to answer any questions if you have.
Thank you so much, Fabio. I don't
You're
know
very
if
welcome.
Fernanda has a question. And se alguém se sentir desconfortável em falar inglês ou de perguntar, pode fazer a pergunta em português, a gente traduz ou colocar no chat também, tá bom? Fê, pode falar.
Hi again, Fabio. I'm Fernanda
Hi,
Marchiori.
Fernanda.
I'm the person who is currently doing the fecal transplant here in pet care. My English is not very good. I understand better than I speak, but I will try my best.
So far I understand what you're saying. And if you want to ask in Portuguese, then maybe Sibele can translate or.
Okay, perfect. First of all, thank you for the wonderful lecture. As I said before, I'm a huge fan. And I have a question. I have a patient that is a lot similar like looping that you described. He has the history of recent antibiotics use. And we try diet, we try probiotics, and he doesn't respond. So I did the index dysbiosis, and he has dysbiosis, but the Peptacetobacter iranonis is within the normal range. So in this case, is valid to do the procedure or not?
So what we know, so the answer is yes, because if in your workup FMT was the right treatment strategy to try, I will try it anyway, because sometimes we're surprised. I showed you in dogs, but it's probably true in cats as well, that they respond even if they're not severely dysbiotic. Also, because if you consider FMT, it's a huge boost of immunomodulatory postbiotics. So it is not just the bacteria, the live bacteria that are actually working, but also what they produce. Okay. And so in our study, 50% of dogs had no dysbiosis, and they improved with FMT. And the other reason why I would try is that there are some cats whose iranonis actually are antimicrobial resistant. Okay. There's a nice study they did in cats with metronidazole, and they identified 2 cats. Well, all cats had very severe dysbiosis with no iranonis, but 2 cats, they had a normal dysbiosis index and a normal iranonis, and then they isolated the iranonis, and it was resistant to metronidazole. But I would still try FMT, and my advice would be to try to, according to the severity of the signs, the duration of the presentation, try perhaps 1 to 2 FMTs, 1 to 2 weeks apart. I find the repeated FMT a key for improvement. When I was doing it only once, With the exception of some very mild cases, the majority needed two. Okay, so now for me, one treatment means 2 FMTs. 2 treatments, 4 FMTs. And you can wait. I mean, once you finish your treatment, what we do, if there is a chance of repeating the index, we do that, but not before a month after, because we want to make sure that what we measure, it's actually now belonging to the patient and not just the remnant of the donor. Of course, the index is quite expensive because the only lab, at least in Europe, the only lab that run this test, the validated one, is the University of Texas, but that's in the States, or IDEX. And it's quite expensive. So not all the clients let me repeat it. Okay, so sometimes we just do it blindly without the index, and we monitor clinically. So I would do it in this case. Yeah.
Nice. Thanks so much for your answer. Perfect.
We have the same problem here about the price of these exams, because we have one lab here. It's run by Patricia Uba. She was from the Texas lab.
I know her.
But it's still very expensive for us, even though it's running here. We have 2 questions in the chat. The first one is about, do you use FMT in pets with GI upsets after chemotherapy?
This is another application we're actually considering to study. I'm pretty sure it would work, because in people that now there is evidence now of FMT to prevent or manage GI toxicity from chemotherapy. If you think about it, what oncologists typically do to manage the diarrhea from certain oral chemotherapy is to give metronidazole, right, or Tylose, antibiotics anyway. And the reason why they work is not because they have a bacterial infection, is because they have a disruption of the intestinal environment, and often they have dysbiosis. And antibiotics help when you have a lot of bacteria attached to the mucosa. So I actually discussed with our oncologist whether he'll be happy to do a study, perhaps comparing the 2 strategies. But my feel, because we haven't applied FMT to those cases yet, but I think it would work. I have no concerns regarding the side effects, because if you think about puppies with parvoviral infection, they have literally no mucosal barrier, and they have the most severe intestinal damage. They're often neutropenic, and there is no evidence of. There are 3 independent studies that show no side effects. So I would say for an adult dog, perhaps neutropenic from chemotherapy would be the same. So I wouldn't be too concerned.
Thank you.
It's an excellent question.
Yeah, about allergic animals. The food of the donor, is it a problem?
This is another question that we hear often, and the answer is we don't know. I mean, we don't recommend to feed the donor like a hydrolyzed or elimination diet unless we have evidence that the recipient actually has a food intolerance or food hypersensitivity, because there are isolated reports of dogs that after FMT developed like allergy-like reactions when they have FMT. And so it depends on the history of the recipient. Okay, so if we are sure that there is no hypersensitivity, then it doesn't matter. I mean, for example, our donor eats a normal maintenance diet. I mean, it wouldn't be even considered one of the, like a top range diet. Her index is systematically, consistently -4 over the years, with loads of Faecalibacterium. And so we didn't ask the owner to change the diet. So But if there is a history of hypersensitivity, perhaps it would be advisable for a couple of weeks before the donation for the donor to eat like an allergenic or like a very hydrolyzed diet to reduce the risk of a hypersensitivity reaction. Yes.
Okay, thank you. There's another 2 questions. Do we have time for that?
Let's say 2 minutes.
Okay.
So 1 minute per question.
With a patient with gastritis, even though they don't have diarrhea, just vomit, they would benefit with FMT.
Okay, so generally, I'd say who knows, but what I can tell you is that there are cases with dysbiosis that will show only upper GI signs, almost like looking like dysphagia or dyspepsia, like in people. In our population, there were at least 3-4 cases that had no diarrhea and just almost like regurgitation or reflux and poor appetite, bloating, and they responded to FMT. And when we saw the index, half of those were dysbiotic and half were not. What we think is that perhaps these cases have like a disruption of the gut-brain axis, and so the FMT actually helps modulating that. So it's certainly worth trying, especially if the index is abnormal. And you'll be surprised in dogs, but also in cats. You have cats with no anorexia as the only clinical signs, and they have severe dysbiosis. So you don't necessarily need diarrhea to have dysbiosis, and therefore for FMT to work.
Great, thank you. I think you answered that in the lecture, but they want to know about the frequency. How many times we need to repeat the procedure?
It really depends on the type of case. For example, young dogs with antibiotic-induced diarrhea are fine with just one treatment. And dogs with severe chronic enteropathy, like the cases from Sweden, they will need FMT. If they respond, they will need FMT every 3 to 4 months. Sometimes the owner actually knows, because when the winter starts and viral infection starts, dogs with chronic enteropathy usually have relapses, and the owner tells you, I need to do an FMT because the signs are coming back. And in my experience, typically every 3 to 4 months you have to do that. But in our study, as you saw, half of the cases did 1 to 2 FMT and they were fine for a year. So it depends on the severity of the dysbiosis, I think. And what I would say is that if they don't respond to 2 FMTs, 2 treatments, so say in my case 4 FMTs, so 2 treatments, then they're not going to respond to a 3rd treatment. Okay, so they probably, the disease is too severe, or they have bile acid diarrhea, so they need to try a bile acid sequestrant, or they need to do a multimodal like medical treatment. This is my experience. Or they have neoplasia, which we do not expect to respond to FMT.
Great, thank you so much for your time. I know you are very busy.
Sibeli, Fabio, Carol Papalardo here. Great to see you.
Carol!
Great to see you. Thank you for lecture again.
I didn't know you were here. Carol is a friend of mine, or at least now we call each other friend, and we are bonded by Italian ancestry. So, and she's very good, very good.
My father, thank you. For us, it's easier. A gastroenterologist is easier to understand these points, but I think for another specialties, it's not so easy to understand the FMT and understand the indications and about this dysbiosis is not so easy for another people, another vets, I think. No, but thank you
Absolutely,
again.
I agree. Thank you for being here, for following me. So I'm gonna say, have a great rest of the day. You probably now need to work. I need to wrap up and hopefully soon go home. And thank you so much for the invitation.
Thank you so much
Thank
for
you, Fab.
accepting the invitation. Thank you for that excellent lecture. I hope to see you more times. When you come to Brazil, have to visit us.
Absolutely. I'll make sure that I'll be in touch if I'm coming to Brazil. I definitely will come because I love Brazil. So I'll let you know.
And maybe there will be an invitation from us. Let's see.
See.
Cross fingers. Thank you so much, Fabio.
Obrigado.
Bye,
Obrigado.
Fabio. Thank you for your time. That was amazing.
Ciao. Ciao. Bye bye.
Bye bye. Pessoal, eu ia pedir para vocês ficarem mais um pouquinho, porque a gente escutou, né, agora o Fábio falando, mas a gente tem o serviço agora também, né, de transplante de microbiota fecal. Stephanie, você quer fazer as honras para chamar a Fê?
Bom, pessoal, obrigada pela presença de todos até agora. A gente vai só finalizar agora chamando a Fê Marchiori. Não sei se todos vocês a conhecem, mas ela faz parte do nosso setor aí de gastroenterologia e ela que está responsável pelo serviço de transplante fecal dentro do Pet Care. Eu sei que tiveram algumas dúvidas quando a gente começou a divulgar o serviço, então a gente trouxe ela nesse momento, junto com a presença do Fábio, para esclarecer um pouquinho e nos colocamos à disposição também. Então, Fê, obrigada pela sua presença, pela sua disponibilidade, e agora a hora é sua. Obrigada.
Obrigada, Esté, eu que agradeço. Nem precisava apresentar, menina, imagina, mas brigadão, viu? Eu ainda tô meio nervosa, que eu fui, gente, falar inglês com uma pessoa que você admira. Meu Deus do céu, que nervosismo. Mas deu certo. Deixa eu compartilhar aqui minha apresentação. Eu preparei uma apresentação super rápida, mais para vocês entenderem e conhecerem como que funciona o serviço, né, atualmente aqui de transplante fecal. A gente tem algumas novidades também que eu vou anunciar agora. Mas, de qualquer forma, se porventura forem surgindo dúvidas nas rotinas, tanto de veterinários aí da nossa equipe, quanto os nossos veterinários parceiros, eu me coloco super à disposição para poder discutir aí os casos individualmente, tá bom? Deixa eu só ver aqui. Tá aqui, share. Tá aparecendo para vocês?
Tá sim, Fê.
Fechou. Bom, então, deixa eu só minimizar aqui. Atualmente, o transplante fecal no Pet Care, eu sou a responsável por realizar os procedimentos aqui em São Paulo. A gente começou, né, recentemente a realizar no Rio de Janeiro também, com a gastroenterologista da nossa equipe, que é a Ana Lúcia, tá? Aqui no Pet Care, a gente faz em todas as unidades, né, Pet Care e também no Vet Quality. Como o Fábio, acho que explicou um pouquinho na palestra dele como que funciona toda a triagem de doadores, e essa triagem ela é bem desafiadora. Atualmente, a gente adquire as nossas amostras de um banco de fezes do laboratório Stonewall, né? Só para, situar vocês, o Stonewall ele foi fundado pela Patrícia Aishi, né? Que ela fez o doutorado dela com Jan Chudovsky, não sei falar o nome dele direito, enfim, que foi quem, né, inventou, digamos assim, o índice de disbiose. O doutorado dela foi com índice de disbiose e ela que trouxe isso para o Brasil e ela fundou, né, esse laboratório, que é referência hoje em gastroenterologia, e tem um banco de fezes do qual a gente está adquirindo as nossas amostras. E essas amostras atualmente estão armazenadas no Vet Quality, e a gente faz o transporte delas para as unidades conforme a necessidade. Para pacientes que já são atendidos pelos nossos, né, gastroenterologistas, o agendamento é de forma direta comigo para realizar o procedimento. Para pacientes encaminhados, a gente sempre pede para passar por um procedimento de triagem, minimamente para a gente entender qual é o caso, né, desse paciente, e também determinar o melhor protocolo para ele. Acho que uma coisa que talvez vocês notaram com a palestra do Fábio é que a gente tem diversos protocolos descritos na literatura, tem uma forma que a gente tem trabalhado, né, em relação a esses protocolos, de tentar padronizar o máximo possível, mas uma coisa que é sempre muito importante é a gente individualizar esse paciente e entender, de acordo com a resposta dele, qual vai ser o melhor protocolo para ele, né? Então, de forma geral, o que a gente tem, né, preconizado é para quadros crônicos de 3 a 4 sessões com intervalo de 2 semanas entre cada. Para quadros agudos, existe a descrição de dose única, que a gente usa um pouquinho menos. Geralmente a gente repete, né, pelo menos de 2 a 3 sessões com intervalo de 48 a 72 horas. E aí, dentro dos quadros agudos, a gente tem, né, uma indicação consolidada aí para parvovirose. A literatura descreve até 5 sessões ou até a diarreia cessar, né? Então, novamente, vai depender muito do quadro que o paciente apresenta para a gente individualizar melhor esse protocolo. Vai, peraí. Ai, agora foi. Bom, então, o Fábio também abordou um pouquinho disso na palestra, mas só para, né, também poder passar para vocês em relação ao que a gente está preconizando em relação ao preparo do paciente. A gente recomenda o jejum alimentar 2 horas antes do procedimento e realizar passeio 1 hora antes para tentar estimular a defecação, para que esse cólon aí esteja vazio, para a gente conseguir introduzir esse material fecal do doador com uma maior eficácia. De formas de administração, né, a gente tem diferentes formas de fornecer o transplante fecal, via enema, pode ser realizado via endoscopia ou colonoscopia ou cápsulas orais. Atualmente, a forma que a gente tem, né, administrado aqui no Pet Care é via enema, tá? Que é uma forma de administração que costuma ser rápida, que, como o Fábio falou, não precisa de sedação, a não ser em gatos, né? Que aí a gente vai falar um pouquinho melhor de gatos agora também, que geralmente a gente recomenda o uso de gabapentina. Depois da aplicação, né? Que aí a gente vai calcular a dose para esse paciente, fazer a introdução da sonda com bastante lubrificação para gerar o menor desconforto possível. E aí, depois da introdução desse material fecal, a gente mantém eles em estação por 15 a 30 minutos pós-procedimento, né? Como o Fábio falou, não passeia pelas 6 horas, né, posteriores, exatamente para não estimular peristaltismo, e mantém o paciente em jejum, idealmente por esse período também. E eu costumo recomendar o uso de fralda, mais no sentido de inibir que ele defeque, tá? Tem pacientes assim, né, que muitas vezes a gente vai fazer o transplante, eles vão estar com diarreia, então eles não vão conseguir reter o tempo que seria preconizado como o ideal para que esse transplante realmente faça um bom efeito, que a gente preconiza aí pelo menos 4 horas, né, de 2 a 4 horas, idealmente 4 horas, mas, enfim, né, se a gente tem tempos inferiores a esse, a gente sempre vai reavaliar, né, a resposta do paciente, mas se esse paciente elimina o conteúdo, né, até 30 minutos pós a introdução do material, geralmente é indicado repetir esse procedimento, tá? A resposta esperada, geralmente a melhora da consistência das fezes, considerando então, né, no paciente que tem diarreia, ela pode acontecer 48 a 72 horas depois, eu já vi acontecer até antes do que isso, mas por uma avaliação mais adequada da resposta mesmo, né, em relação a esse procedimento, a gente recomenda aguardar de 7 a 10 dias. Além da melhora da consistência das fezes, muitos pacientes acabam relatando a melhora de outros sintomas também, sejam sintomas do trato gastrointestinal associados, como, por exemplo, a parte de náusea, de vômitos, de inapetência, ou até mesmo sintomas relacionados a outras comorbidades, né? Então, a gente já viu, né, um paciente que tem, por exemplo, uma dermatite alérgica em conjunto, que recebe transplante fecal e que melhora também a condição da pele ou minimiza aí as crises deles, tá? Pacientes que não apresentem resposta positiva depois da segunda sessão não tem indicação de dar continuidade ao tratamento, reforçando o que o Fábio acabou de falar também, né? E o transplante fecal ele pode ter efeitos colaterais, apesar de serem raros, né? Mas podem acontecer. E esses efeitos colaterais incluem diarreia, né? Para o paciente que já está com diarreia, às vezes piora dessa diarreia, flatulência, borborigmas ou náusea, que geralmente acontecem até 48 horas após a realização e costumam ser de baixa intensidade, tá? Aqui é só para ilustrar um casinho que a gente está tendo essa semana de uma cachorrinha que está internada no Morumbi com parvovirose e a gente está fazendo procedimento de transplante fecal nela. A gente hoje vai para a terceira sessão. A primeira sessão ela defecou mais ou menos meia hora depois, porque assim ela ainda estava, né, com quadro de muita diarreia líquida, né, com uma frequência bem aumentada. A gente fez o transplante, ela defecou depois de meia hora. Eu falei, putz, né, não foi nada, né? Do meu transplante ali, vamos marcar já o próximo para daqui 24 horas, né, para a gente poder reforçar. E aí, assim, por mais que eu tenha achado, né, que ela eliminou de forma precoce, de que talvez não tivesse tido efeito, no dia seguinte ela começou a ter uma melhora da consistência das fezes e do estado geral. Então, a gente fez o protocolo para ela, a gente está fazendo protocolo diário a princípio, né? E até agora a gente tem observado um bom resultado, tá? E a novidade, né, que eu quero compartilhar em primeira mão com vocês é que a gente iniciou o serviço de transplante fecal exclusivamente para cães, mas agora a gente está com uma parceria, né, com uma veterinária parceira nossa, que é a Aline Eng, que ela está atualmente fazendo, né, a tese de mestrado dela na USP, com transplante fecal em gatos, e a gente fez uma parceria que ela tem um doador, né, que foi amplamente testado, né, seguindo aí todas as diretrizes do consenso de transplante de microbiota fecal que a gente tem, e agora em parceria com ela a gente começou a oferecer também um serviço para gatos. Então agora o nosso serviço está completo. Bom, é basicamente isso, gente. Queria agradecer a presença de todos e caso alguém tiver alguma dúvida, eu estou aqui à disposição.
A gente agradece, Fê, por esse resumão aí no final. Como a gente já falou, né? A gente está à disposição, tanto dos veterinários internos quanto dos nossos veterinários externos, e agradecer também a presença de todos vocês. Essa reunião clínica ela vai ficar gravada, então a gente vai fazer a transcrição e tradução para a gente conseguir disponibilizar também, caso vocês tenham qualquer outro tipo de dúvida. E estamos por aqui, tá bom? Contem com a gente e bom dia para vocês, bom trabalho.
Obrigada, pessoal. Bom dia.
Tchau, gente.
Obrigada,
Tchau.
gente. Foi ótimo. Tchau, tchau.
Obrigada, pessoal. Obrigada, Jamara. Um beijo. Tchau, gente.